All right, let's dive into a topic you are going to see constantly on a surgical rotation: acute calculus cholecystitis. We're going to break down its management into a clear, algorithm-based guide that you can actually use on the wards. Think of it as a practical playbook for a super common surgical emergency. So picture this. You're on call. A patient rolls in with that classic right upper quadrant pain, a fever, and a positive Murphy sign. The ultrasound confirms it. It's acute cholecystitis. The attending turns to you and asks, "So what's the plan?" That's exactly the question we're here to answer. Okay, first things first, let's make sure we're all on the same page. Acute calculus cholecystitis, or ACC, is basically this syndrome of right upper quadrant pain, fever, and a high white blood cell count. It's all about an inflamed gallbladder, and it's almost always caused by a gallstone that's blocking things up. This is not just biliary colic, okay? This is an active, full-blown inflammatory process. Okay, so before you even start thinking about the OR, every single one of these patients gets the same fundamental supportive care. We're talking IV hydration to get their fluids up, good pain control. And by the way, our sources actually lean towards NSAIDs like ketorolac first, broad-spectrum IV antibiotics, and of course, keeping them NPO, nothing by mouth. Now, here we are at our first major decision point. The patient is getting supportive care, they're more stable, and now you have to ask the most critical question of all. Is this an absolute surgical emergency that needs to go to the operating room right now? And this slide, this is your must-act now cheat sheet. We're talking about things like a gangrenous or, even worse, a perforated gallbladder. Emphysematous cholecystitis, that's when there's gas in the gallbladder wall. That is a huge red flag. And finally, any patient who's just getting worse. They're becoming hemodynamically unstable or their pain is just out of control. These patients, they bypass the whole algorithm and go straight to the OR. Okay, so for the vast majority of patients who don't need to be rushed to surgery, we hit our next big fork in the road. And this one is all about risk stratification. The crucial question becomes, is this patient actually a good candidate for an operation? This answer is going to determine their entire treatment path. So let's start with the main pathway, the one for good surgical candidates. This is by far the gold standard approach for most people. And the recommendation here, it's crystal clear: early cholecystectomy. And that means doing the surgery during the same hospital admission. Why? Well, because it solves the problem once and for all. It prevents all those recurrent gallstone issues, which, by the way, happen in up to a third of patients who are managed without surgery. Now, what's really interesting is how we define early. The ideal window, the sweet spot, is within 72 hours of symptoms starting. That's when the inflammation is usually less severe and easier to deal with. But the evidence has really pushed this window out. It's now widely accepted that operating within 7 days is way better than delaying, and the World Society of Emergency Surgery guidelines even support surgery up to 10 days out. So while sooner is better, we've got a lot more flexibility than we used to think. When it comes to the surgical approach itself, there's really no debate. Laparoscopic cholecystectomy is the undisputed champion here. I mean, the data is just overwhelming. It leads to lower mortality, lower morbidity, shorter hospital stays, and fewer wound infections. Open surgery is really just reserved for the most complex cases or when a laparoscopic procedure just becomes too difficult to finish safely. So what about patients we traditionally think of as high risk? Well, as you can see here, the guidelines have gotten way more aggressive. For older adults, even those over 80, early surgery is linked to lower one-year mortality. For patients with stable cirrhosis or for those who are pregnant, a lap chole is still the standard of care. The big takeaway is that we're operating on more of these patients and they're actually doing better because of it. All right, let's switch gears and move to the alternate pathway, the poor surgical candidates. What's the plan for patients who are just too sick or have too many other health problems for an immediate operation? For these folks, the strategy shifts completely. It's kind of a two-pronged attack. First, we hit them with aggressive non-operative management with antibiotics. Then, if they're not getting better or they're septic, we move to gallbladder drainage. Now, it's so important to remember this is a bridge, okay? It's a way to cool things down, not a definitive cure. So we have two main ways to drain that angry gallbladder. The most common is percutaneous drainage. That's where a radiologist sticks a tube right through the skin into the gallbladder. It has the highest technical success rate. The alternative is an endoscopic EUS-guided drainage. This is a great option for patients where that percutaneous approach is unsafe, like someone with a lot of fluid in their abdomen. Some studies even suggest it leads to fewer reinterventions down the line. And drainage works to a point. It gets the acute cholecystitis to resolve in about 85% of patients. It gets them over that immediate hump. But you have to remember, the gallstones are still in there, which means the problem can and often will come right back. And this right here, this is the kicker, highlighted by the famous chocolate trial. Even in a high-risk, fragile group of patients, the ones who got an early cholecystectomy had way fewer major complications, only 12%, compared to a staggering 65% in the drainage-only group. And most of those complications? You guessed it, recurrent disease. This just hammers home that surgery, whenever possible, is the better long-term strategy. Okay, so your patient has been stabilized with a drain. We're not done. This is where we have to close the loop and figure out what their path forward is. And this creates a really clear decision tree. Path 1. The patient's condition improves. Great! Their surgical risk should be reassessed, and a lot of them will now be good candidates for a delayed cholecystectomy. Path 2. They fail to improve after about 3 days. Uh-oh. Now you have to suspect something worse, like gangrene. At that point, they need an emergency cholecystectomy, no matter what their initial risk was. All right, let's boil all of this down to the bottom line. What are the absolute must-know takeaways from this whole management algorithm? First, let's be real about the risks. This chart shows it plain as day. While a cholecystectomy is generally safe, the 30-day mortality risk definitely increases with age. Look at that jump, from just 0.2% in the 50 to 64 group, all the way up to 4.5% for patients 80 and over. Age is a huge factor we have to respect in our decision-making. So the crucial points to burn into your brain are: 1. Always start with supportive care. 2. Your very first job is to rule out a true surgical emergency, like a perforation. 3. For good surgical candidates, early lap chole is the gold standard, period. 4. For those poor surgical candidates, remember, drainage is a bridge, not the final destination. And 5. You must always reassess those patients after they've cooled off, because the goal is still to get them that definitive surgery. And that leaves us with this final, really challenging question that clinicians face every single day. Your high-risk patient is now stable after their drainage procedure. The guidelines are clearly shifting towards getting these patients to surgery earlier. So, what do? Do you operate now, accepting that upfront risk, or do you wait and risk them coming back even sicker? That's the central tension we all have to navigate.